when you take this thing out, what you will find is a tubing. This particular one has numbers on it, many of them do not. And it will have this one little connector with it that will either be just stuck in here, it may be like this, with the blue air vent attached to it. And what you may want to do when you first take it out is you wrap it around your hand or your gloved hand and just squeeze a little bit like this, because what that does is it helps to curve it down in the direction you're going to go when you start. Okay. Now before I put my gloves on, I want to tear my tape. Okay. So we're going to take some tape. I'm going to have a couple of fairly long pieces. Then for our purposes, a relatively short piece where you make pants and a shirt. And what I'm talking about by that, you take it and you tear it in half part way. So what you have is a pair of pants and a shirt. Okay? And then you need one little piece. You need either to have a little piece of tape or preferably a Sharpie. Because somebody mentioned about if you had to put it in further and there goes the tape. Good point.
Any color but black.
Yeah.
And if you have one with you, you can use it today.
You can use it today, yeah. Somebody had a purple one yesterday and they were using that. Okay. Now these markings on this tape, note, these are centimeters. So there's 1, 2, 3, 4, 5 centimeters between 10 and 15. So 2.5 of those is an inch. So it's 2 inches every 5 centimeters, give or take. Okay? Okay, so I've got my tape torn, and he knows what's going to happen, poor guy. And I put a towel on him. If the patient is really distended and has a lot of pressure built up in his stomach and you're going in to drain it, probably when that tube hits the stomach, he's going to just spew. And you have to have a cleanup job. So you may want to put this way, you may want to put it long way, you may want to put another one across, you may want to put a chuck over top of him if he's real distended. A normal insertion isn't going to cause that necessarily. Okay, so this is not sterile gloves, so you're just going to put your gloves on. Okay, now there are questions you want to ask before you start the actual procedure. Have you had any stomach surgery? So this guy has not, so he can use a straw. Okay, that's question 1. Question 2, have you had any recent, last 6 to 9 months, nasal, sinus, oral surgery? Because as you're going in, you don't want to get into, for instance, a sinus that's been operated on and isn't fully healed yet. Oh, do you have any blockage in your nose, such as a deviated septum? Then you're going to check which nostril is more open. So you're going to plug one, sniff, sniff, plug one, sniff, sniff. Whichever one's more open, we're now going to block. Aren't we nice? Whichever one you can breathe better out of, we're going to take care of that. Okay, so you've got everything ready here. And you're going to take your syringe, put about 30 milliliters of air in it. Wow, this one's really stiff. And we're going to put that here at the end of the tube. And then this, because it's hollow, we don't want stuff running out if he's got a lot in there that comes out real fast. It's always blue to blue. So that goes in, and you can see the other end is closed. So nothing's going to come out of there. All right? Then we are going to lubricate so we're ready to go in. Now, initially you want as clear a shot as you can, so you have him lean his head back. You may take the pillow out if he has trouble doing that, or he may be able to just lean it back. you're going to go in quickly for about the first 6 inches or so. Because what we're doing is we're coming from here to the back of his throat. 5 to 6 inches, so you're gonna go in quickly, okay? So what you wanna do before you go in, approximately how far do I need to go in? You're gonna go from the tip of the nose, so you wanna do this before you lubricate, to the bottom of the earlobe. Then from there to the bottom of the xiphoid process, and many books, that's where they stop. But if I stop at the bottom of the xiphoid process, what they have found in clinical trials is that a lot of times that tube is not actually down into the stomach, or is just barely into the stomach. And so clinical studies now say, add to that, go another 4 inches if you're further down the stomach, fine. And that should bring you somewhere between 60 and 65 on these mannequins. So I'm at about 61, and then that's where you use your little tiny piece of tape, or your marker preferably, to mark how far you want to go in. So I just create a little flag here so I know when I get, that should be right up against his nose when it's in where it belongs. Okay? Then we're going to do again, head back, in fast, choke, choke, back up, head forward, glug, glug,
Swallow,
glug,
swallow,
glug.
swallow.
Then you want to attach it to the cheek, so it's not going anywhere while you're doing what else you need to do. And this takes, if you try a small tape, it isn't going to hold, people. So we're going to take a nice long tape and hope that it'll hold. Tape does not hold well to these mannequins. Okay. Now I need to check placement. Is with an air puff. Upper left quadrant over the top of the stomach. I've already got my syringe in place. And I'm listening for the sound of air entering the stomach. That is not considered an adequate test for placement. In fact, it's dangerous to consider that an adequate test for placement, because even if it's in the lung, you're going to hear the puff of air go in. You cannot verify with that. That's not considered a reliable indicator of placement. Now, when you have somebody who has tube feeding and they've been having tube feedings, and the tube is still in as far as it was before, and you stopped tube feeding a few hours ago and you're going to start it up again, if you do the air puff, that's considered adequate for continued placement of a tube feeding. But for suction, you want to be absolutely sure you're in the stomach. You do not want to be in the esophagus when you start feeding or when you start suctioning. And you do, what if, okay, the next thing you're going to do is pull some juice out. You've already got the syringe in place. So I'm going to start drawing some fluid out. Now, if you're not using pH paper, and hospitals don't, but if you're doing home health, you'll need pH. Then you can just shove this back in because it's his and he can have it back. And go on with your securing the thing. Okay? Because you've already had 2 tests, the air puff and the color of what's coming out, as an indication of the fact that you're in, okay? But we're going to say, okay, we're doing this at home, so I also need enough fluid to test the pH. You'll never see pH paper in the hospital. It might be in the lab, that's the only place you'd see it. So you're gonna pull out until you have just a little bit of fluid here. Now, when I detach the syringe at any time, if I'm gonna have either this or this open, I must thoroughly crimp the tubing. And I mean, not like this, because stuff can still get through. I mean like this. Thoroughly block it. Then you can take your syringe off and put this in place and let loose of it. And put your little bit of fluid onto your pH paper and verify, okay? This is not done in the hospitals because there's another way to check placement, and what is that?
X-ray.
X-ray, okay? The tip of this tube is radio opaque, so they can see on an X-ray where it is. And you want to be sure that it's well down into the stomach. That's why the extra 4 inches. Okay, so now we say, okay, we're pretty sure we're in. We haven't had the X-ray yet, but I'm sure enough that I can go ahead and fix this in place. I'm going to verify that my number at his nose is still what it was. or that the mark is still where it was, okay? And I'm going to tape. And now I take my, if I have the real dressing, which you may or may not have, all you do is you put the one end of the bone on the nose and the other end wraps around the tube. And that's all. If you are using your tape, you put the shirt on the nose and you wrap the legs of the pants around the tubing. The first one goes clockwise or counterclockwise, the other one goes the opposite direction. So that one went clockwise, this one must go counterclockwise. And you just tape it to itself, and that tube's not going anywhere. Okay, now I've done the x-ray, I've verified. I also can do this before the x-ray, and it's not a bad idea. You're going to take a piece of tape, bring it around the tubing and up onto itself, and you take your safety pin and you pin it to the gown. Okay? And you want to do that leaving some give here so it doesn't pull on it. But that's just one more way of preventing it from pulling out. Now, this has been verified by x-ray now. Placement has been verified by x-ray. Now I'm ready to attach it to suction. If you have suction in the hospital, it's going to be like that. It will be to the vacuum plug on the wall. You see that little meter? That's how you're going to set the pressure. Your rubric tells you what pressure to set, both for a bedside portable, which you might be using at home, and for in the hospital, for wall suctioning. That's what they call that, is wall suctioning. Wall suctioning, the doctor will order, he won't order the pressure, because you should have some idea what pressure it should be at, but he can order intermittent suctioning or continuous suctioning, and you would want to chart what you set up. So that's one of the things you would want in your documentation. Okay, now this has a Yankauers on it. Did you all learn how to use a Yankauers in 101? Okay, Yankauer is just a tube, and it's for oral suctioning, and you can give that to the patient and they can do their own oral suctioning, or you can use it for oral suctioning. This kind has a cover over it to keep it clean in between, but this is certainly not going to be clean because it's going into the mouth and it goes in and out maybe all day long. If you are using this for oral suctioning, you're going to go into the cheek pockets, between the lip and the teeth, all the way around, and the lower, under the tongue, and then slide it down on either side of the tongue, not right down the middle where you triggered the gag reflex. This is deliberately made large enough that you really can't get it very far down the throat, and you don't want to, because it'll choke the patient. But the patient can do his own oral suctioning if he has a lot of oral secretions. Now, you see that this still has a plug on it. This tube may very well be full of liquid. You must crimp it off. Anytime you're going to open the tube, you must crimp it off, and you must thoroughly crimp it off. The first time you don't, you'll never forget again. Okay? So this is going to come off. Now you have this other hollow connector that was on the tube in its packaging. It comes here, and your suction tube connects to that. And this one stays on here. Now you can let it loose and start your suctioning. Okay? If this patient needs to go down for a test or something, you can go ahead, clamp it off, take this off, put this in here, the patient can go for their test. And then when they come back, you simply reattach this. Okay? So that's your suctioning. You're going to be sure it stays clear, that it's continuing to drain, and you're going to keep track in the collection receptacle. These are marked with numbers, and what you'll do is with the Sharpie, you're going to get down at the level, and you're going to mark where it was at the beginning of your shift, or the previous nurse will mark at the end of her shift, and then at the end of your shift, you're gonna mark again, and you're gonna see how much you got out during that shift. There should be less, if it's bleeding in particular, but you're gonna keep track of that, and when the doctor feels like it's been long enough, and maybe we're ready to go ahead and let stuff get into the bowel now, he's gonna say, okay, let's disconnect and be sure that the patient doesn't still need this. So you're going to disconnect it, and you're going to disconnect, and you're going to keep this in case it's needed again, and give it several hours and see if the patient begins to have distension, discomfort, whatever. And if not, the doctor will say, let's go ahead and take it out. Now, he may very well write the letter, or write the order, disconnect from suction, if in 4 hours, no discomfort or distension, remove. And he may make it all one order. You don't have to contact him separately for an order to remove it. So we're ready to remove it, okay? Towel, again, disconnect from your safety pin. Disconnect from the cheek. On a person, you won't need one this long. It's just on this guy. It's the only way you can get it to stay on. Okay, then you're going to remove your dressing from his nose. And all you do is take the shirt off and bring it down and let it stick to the rest of the dressing. This is in place. You ask him to take a deep breath and hold it. That increases intrathoracic pressure and helps push it out. Now you want to do this quick, you know. Oh, let's just take this out. And you're prolonging the agony, you know. Ready to take it out? Okay, deep breath, hold it. In, wrap, and gone.